Welcome to another episode of the Empowered Fertility podcast, the place where we dive deep into all things fertility. I'm Dr. Brenna Squires, a clinical psychologist and fertility support coach, here to bring you the knowledge, resources, and expert insights you need to feel confident along your journey to parenthood. So let's get started. Hello and welcome back. Today we are discussing something that we don't talk enough about, and that is male fertility. When couples struggle to conceive, the spotlight is usually on the woman, but whether we realize it or not, men make up half of the equation. Male fertility is often overlooked, underevaluated, or undertreated because most people don't know where to go or what to do. Understanding men's reproductive health can make a huge difference for couples trying to get pregnant. And before I continue, I want to encourage you to hit the subscribe button so you don't miss an episode. This podcast is here to help you feel empowered and hopeful on your journey to parenthood. So if you want to learn more about your fertility and your health, as well as what you can do to help get pregnant and have a healthy baby, this podcast is for you. Today, I'm joined by Dr. Lawrence Jenkins, an expert in men's sexual health and fertility. And he's an associate professor at Tulane University School of Medicine's Department of Urology and the director of men's health in New Orleans. He is fellowship trained in male sexual and reproductive medicine, and his practice provides personalized care in the medical and surgical treatments for male sexual and reproductive function. So welcome to the podcast. I'm Dr. Jenkins.
Hi, thanks for having me. Happy to be here.
Yes, I am so happy that you're here. And before we get started in today's topic, can you tell us a little bit more about you and why you decided to specialize in men's sexual and reproductive health?
So it happened, or I figured out during residency. I realized that in urology, a lot of what we do is very kind of already set. So if someone has a cancer, we're going to take it out. Someone has a kidney stone, we're going to take it out. Where infertility, there was still kind of a challenge in trying to figure out what was the cause. And that intrigued me and got me interested to like, hey, here's still an intellectual challenge. The other aspect of it is the patient population. If you're able to help that family who was not able to have a child to then go on to have a child, it's very rewarding.
Yeah, so it's both a big challenge and a big reward when you can kind of figure out the puzzle.
Exactly.
Yes, and I'm really excited about what you're going to be sharing today because in episode 9, in episode 9 of this podcast, I spoke with Dr. Stroud, and he was talking all about what's included in a complete fertility evaluation. And he mentioned that men need to meet with a reproductive urologist and not just a regular urologist. And so for those of us out here, myself included, can you explain the difference between a regular urologist and a reproductive urologist?
So a typical general urologist is not specialized in reproduction. They're good for maybe the base workup. Um, but a reproductive urologist is someone who's fellowship trained, meaning they've had extra year or two of training specifically in reproductive medicine, male reproductive medicine, to both diagnose and treat medically and surgically these conditions for male infertility and what might be causing them.
Yes, and that would seem really important for this particular field.
Yeah, exactly. Because a lot of times, the guys aren't not getting there, and guys hate going to the doctor anyway. So you want to get the right doctor as fast as you can rather than delaying things further and further.
Yes, and that actually answered my question, why is it important for men's fertility? Because if you want the man to go to the doctor, you want him to go to the right one, not just anyone. And so when couples who are facing infertility, why should they see you before you being a reproductive urologist? Why should they see a reproductive urologist before jumping into treatments like IVF or IUI or something like that?
So for male fertility, men are typically 50% of the equation or reasons for why a couple may be infertile. So let's say 50% may be female alone. The other 50% is broken between probably 20% male and female and 30% male alone. So the men are 50% of the equation of what could be wrong. So the recommendation is that if a couple's going to see a female fertility specialist, they should see a male fertility specialist at the same time because um, there can be some things that are easily fixable. Well, not necessarily easily fixable, but potentially easily fixable. So hormone manipulate optimization, just adjusting someone's testosterone production, LH, FSH levels to try and improve sperm production. But other things like a varicocele, which is an enlarged vein coming from the testicle that it causes excess blood to heat up the testicles. Now, the testicles are outside the body to be a few degrees cooler, so heating them up is going to decrease their production of both testosterone and sperm. And then, um, if a patient needs surgical sperm extraction or vasectomy reversal, that would fall into what I do as well.
Yeah, and are those some of the most common male fertility issues that you see in your practice?
Exactly. Yeah, that's why I pointed it out. So those being the most common issues, just getting that initial evaluation, a lot, I say by far the most common is hormone optimization. So just getting a guy's hormones to their optimal levels is by far the most common, and all it takes is some medicine versus going through IUI and IVF, which are significantly more expensive.
That's interesting. That's the first time I've heard really about um, male hormones being important. Can you elaborate on that?
Sure. So for sperm production, uh, the body needs testosterone. Uh, the signaling for that testosterone is coming from the pituitary by a protein or hormone called LH. There's also signaling coming from the same gland for sperm production called FSH is the hormone. And so now a guy who is infertile may often have a very low testosterone or kind of like borderline low. And that could lead to the body not recognizing it being low and thereby not sending extra LH and FSH to the testicle to increase production. Another scenario that comes to play. So not all of the testosterone is available for the body to use. A lot of it is bound to proteins like sex hormone binding globulin. And that leaves the free testosterone and some lightly bound proteins, bound testosterone available. So if one were to only look at the total testosterone and that patient had a really high bound component and thereby a low free component, they would miss that low testosterone signaling or low testosterone production. So I see that quite frequently where, let's say a patient has a testosterone in normal range. Let's say it was 600 when the normal range being 300 to 900. Um, but when I looked at their free testosterone, they're actually below the normal cutoff. So someone who looked at only total testosterone would miss that. So testosterone is important. LH and FSH are important for sperm production and also for erections, which are needed for the sexual activity for the conception.
It's interesting as you were saying all of those things with the different hormones. It jumped out at me that those are some of the same hormones for women, LH and FSH, and those are things that women track or they try to track and they try to look at that, but I've honestly never heard about that for men, but it makes sense that they would have similar hormones in a similar pattern.
Exactly.
Yeah. All more reason why it's important to go to a I like how you called it a men's fertility expert.
Mhm.
I've never
Because
heard that that term before because we don't really think about a men's fertility expert.
because men are definitely part of the equation, and you need a specialist to know what to look for and how to tease those things out and how to optimize them.
Yeah, and why do you think a lot of these things are overlooked?
So part of it, people don't know. Um, People automatically associate the gynecologist with women's health, but don't necessarily associate the urologist with men's health, especially for fertility issues. So if a woman's having issues getting pregnant, they're automatically going to go to their gynecologist,
Hmm.
and then they'll work them up and refer them further. Uh, the guy, one, typically doesn't go to the doctor. Two, typically doesn't know about the urologist and what they can do. And three, doesn't know about a reproductive urologist at that. The other aspect, reproductive urologists are not very common. So I live in New Orleans. There are three reproductive urologists in town.
Wow.
Yeah. So many major cities, there's only a handful or less reproductive urologists who specialize in this.
Yeah. So you have to really be looking for that specifically.
Yeah, exactly.
Yeah, and it's so different because with a gynecologist, you could just find them not necessarily pretty much anywhere, but there's a lot to choose from. And this is very well known. And like you said, it's not very well known that that's considered very important for men's health, let alone how do you find them because they're not very readily available.
Exactly. So there's certain resources. There's the Society for the Study of Male Reproduction. They typically have a Find a Doctor feature. And there's
Oh,
also the Society of Male Reproduction in Urology, and they also have a Find a Doc feature.
well, that's neat. I'll include the links in the show notes because I was unfamiliar with that, and I'm pretty sure many of the listeners will also be unfamiliar with that. So I'll include the links to that. So let's jump into different tests because I know that's what some people are probably thinking. What are the different types of tests that are available for men if they, let's say, they work with you or go to your practice?
So going back to the hormones, that's how we start out.
Okay.
So we start out with getting a hormone panel. I typically check a total and free testosterone, an LH and FSH, an estradiol. That's how we test for estrogen, which is a byproduct of testosterone. Some men convert their testosterone to estrogen more than they should, and that's why we check that. And I'll check a simple blood count. That's my basic set of labs. And then along with that, I'll get one or two semen analysis to check their sperm parameters. Uh, that's the basic test. There's also the physical exam. So some common things found on physical exam that would be abnormal. There's congenital absence of the vas deferens, common in patients with cystic fibrosis traits. Um, that vas deferens is a tube that carries the sperm from the testicle to the body. So if it's missing, then there's ejaculate is not going to have any sperm in it because there's no pipeline. So that's something that will be picked up on physical exam. The other big thing that's picked up on physical exam is varicocele. So I think I said earlier, enlarged veins coming from the testicle, you can identify that on the physical exam. So those are things that are treatable um, that you want to know before you jump into further along the workup cycle as far as how to manage that patient.
Yeah. And then with the physical exam, and I don't know if how many men are going to be thinking this, but I'm curious because for women, we have tons of different physical exams, some that range from you're fully awake to you are sedated. What does a typical physical exam look like?
So office setting, patient's fully awake, we're chatting, and then we're like, all right, stand up, drop her pants. Let me just take a quick feel.
Okay.
Takes 15 seconds and then we're done.
Okay. Whew.
Yeah.
I'm sure
So
some men were probably thinking there was going to be more involved in that one.
yeah, super easy.
Okay.
Guys, that thing to be afraid of.
Okay. Good. That does sound super easy. So are there now that that's the secondary, so you said basics is the lab and then we have this exam. Are there any further testing that's done if you find that there's issues with either of those?
Absolutely. So there's various extra tests to do. If I find that someone's ejaculate volume is low, I may check for signs of obstruction by doing a transrectal ultrasound to look for enlarged seminal vesicles. That would be a sign of obstruction. If someone has no sperm in their sample,
Mm,
then I'll check uh, some genetic tests, a chromosome analysis or karyotype, as well as a Y chromosome microdeletion assay. And what these tell us if there's any abnormalities in the chromosomes or DNA, where the presence of them meant there would be no probability of sperm production, we'd want to know before we do anything extra invasive. So those are the two biggest tests that we're doing after the sample. Anything else is going to be, you know, part of our treatment of, how do we treat it? And then that's when where's the medication, surgical treatments.
Okay, awesome. And with let's say if you look at the sperm and you do a sperm analysis and the mobility is low, the structure is off, or maybe there's a low count, do you do any of the further testing, or that's when you just kind of jump into treatment?
So for motility, okay, so we'll go sample or item by item. So I talked about volume. That's when we're looking for obstruction. The other thing we're looking at in a physical exam, I forgot to mention, is size of the testicle, because that can be a sign of decreased production within the testicle. Now, for the semen analysis, we're looking at volume. Um, we're also paying attention to abstinence interval, because it's very important to think about if you abstain for too long, the sperm has been sitting there for a long time and it degrades. It's a lower quality. And if you ejaculate too close to the date, then the count is going to be lower. So the recommended interval is 2 to 5 days uh, for doing a semen analysis. Now, for when they're trying to get pregnant, we say every other day because we want to get the best sperm, the fastest sperm out there to
Yeah.
swim to the egg.
Yeah.
What was the rest of your question?
If there was just any other specific treatments, like you had said, if there was volume, you want to see if there's an obstruction, if there's like an altered shape. I know I've seen different places where they say the sperm doesn't have the right head or something like that. Is there a different testing that you do for that?
Yeah, so the different shapes in the head, that's going to be, or the morphology of the sperm, that's purely picked up in the semen analysis.
Okay.
Uh, so most of those we don't have treatments for, and we rely on IVF with ICSI to just put the sperm into the egg. Motility, we look at improving their health status, take supplements, um, omega-3 fatty acids, coenzyme Q10, um, as an example of some of the supplements we recommend. There's not great data, but a little data, and every little bit counts in
Yeah.
what we're working with.
Yeah.
So I do have my patients take those. Um, and those can help improve motility. Um, concentration may be a factor of low testosterone or a deep, not enough LH FSH drive. So that's when we may use medication to stimulate, actually, the same medication we use in women, clomiphene, uh,
Oh,
to stimulate LH and FSH production and stimulation of the testicle.
that's so interesting. And yeah, as we are moving on into the treatment side of this episode, Clomid, that's very interesting. And would that be taken similar to the way that a woman takes it with for 5 days, or is it something that's taken at a different dose? No.
No, it's taken differently. So
Okay.
the typical treatment with Clomid is going to be either 25 milligrams every day or 50 milligrams every other day, for a continuous cycle, because sperm production takes about 3 months. So you want to be on the medication for the entirety of sperm production.
Oh.
Same
Okay.
thing with the vitamins. You want to be on it for the entirety of sperm production
That's so interesting. So it's a different dosage and they take it daily or every other day for the full 3 months
or until they're pregnant.
or until they're pregnant.
Yeah.
Yeah. We're hopefully monitoring that, right? Okay.
Now,
So
if you
that's
want,
interesting.
and if we're talking about medicine, so on top of that, I may use HCG, which looks to the body like LH. And that's an injection done 2 or 3 times a week, to directly stimulate the Leydig cells in the testicle, which make testosterone, to then therefore hopefully increase the intratesticular testosterone to improve sperm production. If we don't get it with that, then there's also recombinant FSH, to directly stimulate. sperm production, but that's way more expensive.
Yeah. But it's an option. It's an option that I didn't know about, and I'm sure many men don't know about.
Correct. We do have options.
Yeah.
Not a
I mean,
lot. Have
not a
options.
lot, but some. I mean, and you said it's expensive. Is it expensive as IVF?
Um, no, nowhere near as expensive. So like LH, well, sorry, HCG is probably about on the fertility dose. It's probably about $200 a month.
Mhm.
The FSH, that one, um, I can't think of the price, but I think it's closer to $200 to $500 a month.
Okay. Yeah, and those are on the higher end for medications, but they are also on the lower end for treatment.
Correct. Correct.
Very interesting. Are there any other treatments that you have done with men who are experiencing fertility challenges?
So treatment wise, if a patient has a varicocele, which is the enlarged vein, we can do a outpatient surgery where we make an incision in their groin to get the veins as they exit the abdomen, and we tie them off and separate them so that the blood does not continue to come down from above and collect around the testicle. Um, Easy surgery, takes less than an hour, um, easy recovery, but can be very effective for those medium and large varicoceles that are causing problems.
Yeah. Wow, that's awesome. Not it's awesome that there's again something else that can be done if you see a problem.
And then for those patients who've had a prior vasectomy, we can do
Mhm.
vasectomy reversal. It's not
Okay.
100% effective, but typically 85 to 90% effective at getting sperm back in the sample. Maybe not at the levels that they were before, but getting sperm back in the sample is a plus.
Yes, that's very big plus. And you had mentioned that reversal. It made me think of something. What if somebody had damage to the testicles, like if they had a past injury? Is that something that you have seen before?
So it's something that we screen for. So the biggest issue we have is infections. Uh,
Infections.
so mumps post puberty that can cause testicular swelling. The testicles don't like heat. So febrile illnesses, um, inflammation in the testicle can cause scarring, and that can change the ability for one, the testicle to make sperm, but also for the testicle to deliver the sperm back to the body. Um, the other aspect was COVID-19. There was some research showing some changes in semen parameters post COVID infection. There's kind of mixed data on that, so not quite so clear. And then if someone has trauma, so like an injury to the testicle, that can cause inflammation, and then the inflammation can cause scarring,
Yeah.
thereby damaging production.
And I don't know if this is a stupid question, but with the scarring, is that something that they'd be able to see or feel, or is that something that only that you'd have to do some type of formal evaluation on?
So we may not even see it on a formal evaluation. It may show up on an ultrasound, but a lot of times it's not going to show for anything in particular.
Okay. So we would just see the outcome or the aftermath of it. We might not
Exactly.
necessarily see the scarring.
Exactly.
Very interesting. Very interesting. And so what are what are some of the biggest myths or misconceptions that you've heard about male fertility that you wish people knew more about?
Well, I mean, like, there's the first thing is that there's nothing that they can do. So there's obviously things we can do. Um, it's not true that it's always a female issue. Male are 50% of the equation. Um, Age doesn't matter for men. So men do stay fertile longer, but sperm quality does decline with age. Um, and then thinking that fertility can't be improved, we've already discussed the many ways that we can improve men's fertility status.
Yeah. Those are some big ones. Those are ones that I hear often. And with that, with the improvement, how much do lifestyle factors like stress, diet, exercise, toxins, how much of those things really impact sperm health?
So I can't give you kind of like a hard percentage of how much it impacts, but it impacts the overall health of the patient. So we talk about four pillars, right? Exercise, sleep, and stress reduction as being key factors to men's health overall. So that's really up to the patient to optimize those factors because they do play a role in their overall health. And their overall health is impacted in their fertility. Now, other toxins and factors, obesity, smoking, heavy alcohol use, those are things that are modifiable risk factors that are definitely going to affect fertility, decreasing sperm production and quality. Oh, and I forgot to mention excess heat exposure, like hot tubs and hot water baths. That direct heat is going to heat up the testicle and decrease production. And then it takes 3 months to recover that production.
Oh, so that one is a direct correlation that you can find. Yeah, so no hot baths or bubble baths or saunas. That's good to know for them.
Technically, so sauna is hot air around you. So
Mhm.
technically, it's not as bad as the
Oh,
water submersion, just because the water get temperature transfers so easily
oh,
versus
that's
the air
interesting.
temperature transfer doesn't transfer as easily.
That's good to know. That's so interesting. Um, and can you share a story or example of a patient of yours that came in and it really changed the outcome for them and their journey to conceive?
Um, I guess one that comes to mind is someone who came in with a very low sperm count, and we put them on Clomid. They did Clomid for 3 to 6 months, and afterwards we looked at their sperm count, and they had a very normal sperm count, like very normal. And like even the lab director called me and was like, "Hey, this guy had almost no sperm, and now he's got a great count." And all that was just being on Clomid to optimize their hormones, and then they were able to go on to conceive naturally.
Wow, that's a great story. It's a great story because I've honestly never heard that before with, like you said, almost nothing to so much, and now you can conceive naturally. And how many of those couples out there are told you can only do IVF? That's your only option. And here this couple did this.
Exactly. So that's why we always encourage to see the men's health specialist or reproductive urologist, because there's these cases where, hey, we can do hormone optimization and possibly improve the count of the sperm count so that maybe they were in the IVF category and we downgrade them to IUI, or even better, we downgrade them to natural conception. We're really big on downgrading slash improving the odds. It's less expensive long term, uh, and a lot of patients like it being easier.
Yes, we want it as easy as possible. It's already stressful.
Exactly.
Yeah. And so for men listening right now, what are some simple first steps that you can give them to start um, understanding their fertility health and start to improve it?
So I'll go back to those four pillars: the good diet, exercise, was cardiovascular and strength training, getting good sleep, stress reduction, getting rid of any of those environmental toxins like smoking or significant alcohol use or marijuana. Um, those are the easy factors that a guy can do to optimize their fertility, optimize their potential. The next step after that is go see a specialist to see what their semen analysis is, what their hormone levels are, to optimize it further.
Awesome. Awesome. Thank you so much. And thank you so much for the information that you shared today. So as we are coming to a close, Do you have any final thoughts for the listeners?
So, I mean, I think I would focus on, you know, don't delay care. Like, get checked out early if you think there is a problem. Most guidelines say go get checked out after 1 year of trying, but don't like put it off for like 2 years, 3 years, 4 years. Go. It's a couple's issue, so both partners should be evaluated. Um, and for men, like I said, it's about their overall health. All that plays a role. So focusing on health, focusing on, getting treated for the future.
Awesome. Thank you so much. I appreciate you and you taking the time to share your knowledge with us today.
Well, it's great to help out and give this education to patients out there. And, it's great that you're doing this podcast to educate patients so that they can, go out and get treated and get what's best for them.
Yes, and if somebody wants to reach out to you and connect with you further, how can they do that?
Um, I think the easiest is probably to check out my website, ljenkinsmd.com, and that has all my contact info. I'm also on Twitter and Instagram at ljenkinsmd, but that's how you reach me.
Perfect. Thank you so much. I really appreciate this. And I appreciate you, like I said, taking the time to share with us today. And thank you so much, listeners. I appreciate you as well. I hope you've enjoyed this episode and learned a lot. If you have any questions or thoughts, put it in the comment section, and I will see you in the next episode. Take care. Thank you so much for joining me today on the Empowered Fertility Podcast. If you're looking for personalized support on your journey, whether that's through therapy or coaching, please reach out. Just complete the contact form linked in the show notes, and someone from my team will be in touch with next steps. Remember, you are not alone. You are not broken, and your story is not over. See you in the next episode.